Imagine waiting years for like a really dangerous fire to finally burn itself out.
Right.
You've been told that relief is coming, that the flames are slowly dying down, but then right before the fire actually goes out, your body suddenly decides to just douse the entire thing in gasoline.
It sounds like a cruel trick.
It really does. But if you look at the reality, for millions of people navigating uterine fibroids during that transition into menopause, this is exactly what happens.
It's a very harsh reality.
Yeah, because we typically think of the lead up to menopause as a time when the body's reproductive systems are just, you know, gently powering down, like turning down a dimmer switch on your hormones.
But instead, that dimmer switch breaks, the wiring sparks, and the symptoms just explode.
Exactly. It is a profound and, frankly, exhausting paradox for the people going through it.
It really is.
So welcome to this custom-tailored deep dive. Our mission today is pulling from a massive stack of medical guidelines, clinic resources, and all the latest research to answer a highly specific, often incredibly frustrating question.
And that question is, why do uterine fibroids usually experience a temporary, sometimes brutal worsening of symptoms right before they finally shrink post-menopause?
Right. So whether you are experiencing this roller coaster yourself, or maybe you're supporting a partner or a friend who is, hiding in the bathroom, terrified of bleeding through their clothes.
Which is so common, unfortunately.
It is. Or even if you're just someone fascinated by the hidden mechanics of human biology,
Yeah.
this exploration is going to completely change how you view the body's transition into menopause.
I completely agree. It reframes everything.
Okay, let's unpack this.
Yeah.
Before we can figure out why fibroids go absolutely crazy during perimenopause, we have to understand what they're actually made of.
And more importantly, what they eat.
Yes. Because if we think of fibroids like aggressive, unwanted houseplants taking up residence in the body, we need to know what kind of fertilizer is making them thrive in the first place.
I love that houseplant analogy. So medically, uterine fibroids are known as leiomyomas.
Leiomyomas, okay.
Right. They are benign, which means non-cancerous, tumors. And they're made of smooth muscle cells and fibrous connective tissue that grow basically in or around the uterus.
And looking at the sources, it seems like location matters a lot, right?
Oh, location matters immensely. It
Yep.
dictates the symptoms. You have intramural fibroids, which grow deep within the muscular wall of the uterus itself.
And those cause a lot of cramping, I'd imagine.
Exactly. Then there are submucosal fibroids, which bulge inward into the inner uterine cavity. Those are the ones most likely to interfere with the lining and cause profound, heavy bleeding.
Wow.
And finally, you have subserosal fibroids. Those grow on the outside of the uterus and can expand outward into the pelvic cavity, physically pressing on surrounding organs.
Like pushing on the bladder or the bowel.
Precisely.
And looking at our sources, these aren't rare anomalies at all. The numbers are, frankly, staggering. Up to 80% of women will develop fibroids by the age of 50.
80%.
If you're sitting in a room with 5 women, statistically, 4 of them have had or currently have fibroids.
They are incredibly common, though, not everyone will have severe symptoms, but the research points to a very strong genetic component driving this growth.
Right, I read about the MET12 gene.
Exactly. The MET12 gene mutation is found in roughly 70% of all fibroids. To put it simply, this mutation essentially acts like a corrupted piece of software in the cell's copying machinery.
Corrupted software, so it just keeps running the wrong code.
Exactly. It causes the cells to stop listening to normal growth limits. Instead, they hyperfocus on hoarding hormones.
Wow.
And we also see significant demographic differences that are just crucial to understand here.
Right. The data on African American women is really striking.
It is. African American women have a 2 to 3 times higher risk of developing fibroids compared to white women.
2 to 3 times. That's a massive difference.
It is, and they tend to develop them at a much younger age, often in their 20s. Plus, they frequently experience larger tumors and much more severe symptoms.
So back to the houseplant analogy.
Yeah.
If these tumors are growing because of corrupted cellular software, what is the fertilizer? What are they constantly feeding on to get so large?
They feed directly on the primary female reproductive hormones, estrogen and progesterone.
Estrogen and progesterone.
Right. Fibroids are essentially like biological sponges that are absolutely bristling with specialized receptors for these two hormones.
So they just soak them up.
Exactly. Estrogen acts as the accelerator. It sends the chemical signal to the fibroid tissue to thicken, divide, and proliferate.
Okay, so estrogen is the gas pedal. What about progesterone?
Progesterone comes in and acts as the structural support. It maintains that new growth and prevents the body from breaking it down.
That means, well, because these tumors are biologically programmed to feed on these specific reproductive hormones, their entire life cycle is intimately tethered to a person's menstrual timeline.
You hit the nail on the head. They are exceedingly rare before puberty when hormone levels are low.
Makes sense. No fertilizer, no growth.
Right. Then they thrive and grow during the reproductive years when estrogen and progesterone are surging on that monthly cycle.
And historically, the clinical data shows them heavily impacted by the massive hormone shifts of pregnancy and, of course, the dramatic drop in hormones during menopause.
Exactly.
Which I guess brings us to the core mystery we're trying to solve today in this deep dive. We know fibroids feed on estrogen and progesterone. So what exactly happens to that hormone factory during perimenopause?
That is the big question.
Wait, I always thought perimenopause was the body simply running out of estrogen. How can there be this overabundance of fertilizer if the ovaries are supposed to be shutting down?
What's fascinating here is that perimenopause is not a gentle linear decline at all. It is utter hormonal chaos.
Chaos, okay.
Yeah, perimenopause usually starts in the early 40s. On average, it lasts about 4 years, but for some people, it can drag on for up to a decade.
A decade of chaos. That sounds awful.
It can be. During this window, the communication system between the brain and the ovaries starts to break down. The brain's pituitary gland sends out a signal follicle-stimulating hormone, or FSH, basically shouting at the ovaries to produce eggs.
But the ovaries are aging, so they aren't listening.
Right. The aging ovaries are struggling to comply, so the brain shouts louder, pumping out even more FSH. This feedback loop results in massive, unpredictable spikes and crashes in estrogen levels.
Oh, wow. So instead of a steady trickle of hormones, you are getting these massive tidal waves of estrogen flooding the system unpredictably.
Exactly. And our sources point out a specific mechanical failure that happens during these erratic cycles.
The anovulatory cycle, right?
Yes. The clinical term is an anovulatory cycle. As you navigate perimenopause, your ovaries might gear up, produce all that estrogen, but then fail to actually release an egg that month.
And when you don't release an egg, that throws off the other hormone.
Precisely. Normally, the physical release of an egg is the exact biological trigger that tells your body to start producing progesterone.
Okay, and earlier we said progesterone is the structural support for the fibroids, but it also does something vital for the uterine lining itself. I've seen it described almost like the brakes on a car.
It is the brakes. Progesterone controls the thickness of the uterine lining and balances out the proliferative effects of estrogen. It stabilizes the whole environment.
So if you don't release an egg, there's no trigger, which means there's no progesterone. You effectively have no brakes.
None. You are left with estrogen running completely rampant. This physiological state is known as estrogen dominance.
Estrogen dominance.
Yeah. The massive surges of estrogen continue to thicken the lining of the uterus unchecked, building it up like an unstable snowbank.
Unstable snowbank. That's a terrifying image.
At the same time, this estrogen dominance acts as an all-you-can-eat buffet for any existing fibroids, causing them to rapidly swell and grow right before the reproductive kitchen is supposed to close.
And this perfectly explains the terrifying symptom flare-up. Because the sources indicate that about 30% of newly diagnosed fibroids actually pop up during this chaotic perimenopausal phase.
Yeah, that 30% figure is huge.
And the symptoms are just brutal. I mean, the medical literature describes a phenomenon called flooding.
Right, and we need to be clear, we aren't just talking about a heavy period.
No, not at all. Flooding means bleeding so heavily that you soak through a superabsorbency pad or tampon in less than an hour, often passing clots the size of golf balls.
It's intense.
It's the physical result of that highly unstable, excessively thick uterine lining finally collapsing all at once, right? Because it didn't have progesterone to hold it together.
That's exactly the mechanism. The physical reality of that blood loss is profound. Because the fibroids are also rapidly expanding from those estrogen surges, they just compound the issue.
So it's a double whammy.
It really is. The patient experiences severe pelvic pressure. If you have a subserosal fibroid pressing directly against your bladder, you might feel the urge to urinate every 20 minutes.
Which is exhausting in itself.
And then there's the anemia. The sheer volume of blood loss during flooding frequently leads to severe iron deficiency anemia.
Right, because your body simply cannot manufacture red blood cells fast enough to replace what is being lost.
Exactly. So the patient is left with a heart that has to work overtime just to pump oxygen. That results in exhaustion, dizziness, and shortness of breath just from like walking up a flight of stairs.
Okay, so that chaotic communication breakdown between the brain and the ovaries perfectly explains the brutal, temporary worsening of symptoms.
It does.
But what happens when you finally cross the finish line? Like, what happens when perimenopause ends and menopause officially begins?
Well, menopause is strictly defined as going 12 consecutive months without a single menstrual period.
12 months, so
Right. At this point, the ovaries have completely depleted their functional egg reserve and stopped their erratic surging. Both estrogen and progesterone levels finally plummet to a new, permanent low baseline.
and that's the relief everyone is waiting for.
Exactly. Because the fibroids are now entirely starved of the hormonal fertilizer they rely on, they begin to atrophy. The cells die off and the tumors shrink.
Wow.
Yeah, most fibroids will shrink by 50% or more post-menopause, which usually brings immense life-altering relief from the heavy bleeding and that terrible pelvic pressure.
But there are some major caveats in the data, aren't there? You don't just wake up on day 365 of no periods and suddenly the fibroids are gone.
No, definitely not. The shrinkage process is slow. It can take several years after menopause for those fibroids to fully shrink down to a manageable size.
Years.
Yeah, and there's an additional fascinating biological variable regarding body composition.
The adipose tissue thing, right?
Exactly. Adipose tissue, which is just body fat, actually contains an enzyme that converts circulating steroids into a form of estrogen called estrone.
Okay, so wait.
So if you have a BMI over 25, your adipose tissue can cause slower shrinkage of the fibroids.
Because the fat cells are essentially acting as a backup generator.
That's a perfect way to put it. They provide a continuous, low-dose supply of estrogen to the tumors, even after the ovaries have fully retired.
Wait, if body fat acts as a backup generator, producing estrogen, what happens if a patient goes to their doctor and is intentionally given estrogen?
Ah, the HRT question.
Right. If someone is suffering from debilitating hot flashes, night sweats, and brain fog, they're often prescribed hormone replacement therapy, or HRT. Aren't we just pouring fertilizer right back onto the weeds we just managed to starve?
It is an incredibly complex clinical dilemma. It's known as the HRT paradox.
The HRT paradox.
By reintroducing systemic estrogen into the body to cure the hot flashes, you are simultaneously risking waking up the fibroids.
Right, potentially causing them to grow back or triggering a return of the heavy bleeding.
Exactly. However, the cardiovascular, cognitive, and bone protective benefits of HRT for postmenopausal women are massive. Denying a patient HRT just because they have fibroids isn't always the best overall health decision.
So how does a doctor navigate that? It sounds like walking a tightrope.
It really is. It requires highly customized dosing. A physician might adjust the HRT regimen to the absolute lowest effective dose of estrogen.
Just enough to stop the hot flashes, but not enough to feed the fibroid.
Right. Or they might increase the continuous dose of progesterone to aggressively counteract the estrogen's proliferative effect on the uterine lining.
Like pushing really hard on the brakes.
Exactly. Another very common approach is to utilize a levonorgestrel-releasing intrauterine system.
That's the Marina coil.
Yes. This device delivers a steady, localized dose of progesterone directly into the uterine cavity to keep the lining extremely thin and the fibroids suppressed.
While still allowing the patient to take systemic estrogen via a patch or a pill for their wider menopausal symptoms.
You got it. It's a localized solution for a localized problem.
Okay, so what does this all mean for someone currently in the thick of it?
That's the most important question.
Right. If you know relief is technically coming post-menopause, you might just think, okay, I just need to grit my teeth. I'll buy thicker pads, I'll endure the flooding, I'll take iron pills, and I'll just wait it out.
Yeah, that's a common thought process.
But the medical guidelines in our stack strongly advise against this grin and bear it approach.
They absolutely do. This raises an important question about patient advocacy. How do we actively bridge that gap safely?
Because the physical and mental toll of waiting it out for years is simply too destructive.
Way too destructive. Physically, enduring flooding for 7 to 14 days a month leads to a level of profound anemia that damages your immune system and your cardiovascular health.
And the mental health impact is just devastating. The sources detail how people experiencing this level of unpredictable, heavy bleeding develop severe, chronic anxiety.
It consumes their lives.
Imagine having to plan every single trip outside your house around the exact location of the nearest bathroom.
Mental mapping of every restroom in town.
Right. People avoid daily activities, they cancel vacations, they miss weeks of work, and they isolate themselves because they're constantly terrified of a sudden flooding episode in public.
It completely degrades your entire quality of life. No one should have to sacrifice a decade of their life just waiting for their ovaries to shut down.
So what are the options?
Well, there are highly effective medical ways to bridge the gap. We already touched on the Mirena coil to thin the lining. But if the fibroids are too large or distorting the cavity, doctors might use medications called GnRH agonists.
GnRH agonists.
Yes. These are monthly injections that essentially induce a temporary artificial medical menopause.
Oh, wow. So it just shuts everything off.
Completely. They sever the communication between the brain and the ovaries, stopping estrogen production entirely.
And by starving the fibroids, the sources say these drugs can shrink the tumors by about 36% in just 12 weeks.
Yes, and stopping the bleeding entirely.
Wait, I'm confused though. If GnRH agonists shrink the fibroid by over a third and stop the bleeding, why not just put a perimenopausal patient on those injections for 3 or 4 years until natural menopause kicks in?
Oh.
Why do the guidelines say you can only use them for 6 months?
Because completely wiping out your estrogen levels comes with severe systemic consequences. Estrogen is critical for maintaining bone density.
Oh, I see.
Yeah. If you suppress it entirely with GnRH agonists for more than 6 months, you induce rapid, severe bone loss.
Putting the patient at a high risk for irreversible osteoporosis.
Exactly. These drugs are excellent for short-term symptom relief or, for shrinking a massive fibroid to make an upcoming surgery safer.
But they are not a long-term bridge.
Correct.
Okay, so if the medications have strict time limits, we have to look at procedures. And one that really stood out in the research stack is UFE, or uterine artery embolization.
UFE is a fascinating non-surgical intervention.
Non-surgical.
Well, instead of a gynecologist, it's performed by an interventional radiologist.
Yeah.
They make a tiny pinhole incision in the groin or the wrist and thread a microscopic tube, a catheter, through your arterial system, all the way into the specific uterine arteries that are actively supplying blood to the fibroid.
So they go all the way from the wrist to the uterus. That's wild.
It is. And once they are in position, they inject thousands of tiny sand-sized particles into the vessel.
So what does this all mean? If I'm visualizing this correctly, it's like discovering an enemy fortress. The fibroid itself is just too massive and dangerous to attack directly with traditional abdominal surgery.
I like where this is going.
So instead, you send a team in to dam up the river, you cut off its supply lines, and simply wait for the fortress to starve and surrender.
The mechanism is exactly that. Those tiny particles wedge into the vessels, creating a logjam that permanently blocks the blood flow.
And without its blood supply, the fibroid essentially suffocates.
Exactly. Over the course of the following year, the tissue dies and the tumor shrinks by about half, resolving the heavy bleeding and the bulk pressure.
That's amazing.
It's a highly effective option for someone in perimenopause who wants to keep their uterus, avoid a major surgical recovery, but desperately needs definitive relief before menopause arrives.
Right.
The ultimate takeaway here is that treatment during this chaotic transitional window must be customized. A physician must actively balance treating the anemia, protecting bone health, preserving the uterus if desired, and getting the patient safely to the postmenopausal finish line.
Here's where it gets really interesting and honestly a bit alarming.
Oh, yeah. This part is crucial.
We've established the biological mechanism, right? Fibroids grow rapidly during perimenopause because of those chaotic estrogen spikes.
Yes.
But there's a terrifying exception in the medical literature where rapid growth means something entirely different. And if a doctor assumes it's just perimenopause, they might miss a critical red flag.
You are referring to the risk of leiomyosarcoma,
Right.
which is a rare but highly aggressive type of uterine cancer. And it's vital to clarify for the listener, benign fibroids do not magically turn into cancer.
They are totally separate things.
Exactly. A sarcoma is a completely different malignant cellular entity. The problem is, it unfortunately looks almost identical to a benign fibroid on standard ultrasound or MRI imaging.
That is terrifying.
In the general population, the risk of a presumed fibroid actually being a hidden sarcoma is quite rare. However, the data shows that risk jumps significantly right around the perimenopausal transition.
Because for perimenopausal women undergoing surgery, for what everyone assumes are just benign fibroids, the risk of uncovering an unexpected sarcoma is about 1 in 166.
Yes, 1 in 166.
That is absolutely not a zero-risk scenario, especially when we're talking about millions of surgeries. So what are the actual red flags?
Good question.
How does a doctor or a patient know when a growing mass isn't just a regular fibroid gorging on the perimenopausal estrogen buffet?
The clinical red flags include a solitary mass, so just one single large tumor rather than a cluster of them that is growing at an unusually rapid pace in a perimenopausal patient.
Just one fast-growing tumor. Got it.
Another major warning sign is the response to medication.
Like the GnRH agonists we talked about.
Exactly. If a patient is given those estrogen-depriving drugs and the mass continues to grow anyway, that is highly suspicious.
Because benign fibroids require estrogen to survive. So a tumor that thrives without it is ignoring the biological rules.
Right, it's making its own rules. And finally, any new uterine bleeding that suddenly occurs after a woman has fully completed menopause is considered an urgent red flag that requires immediate biopsy.
And this brings us to a specific surgical technique that has been the center of intense, widespread medical debate over the last decade.
Yes, the morcellation debate.
If a patient does need surgery, like a hysterectomy or a myomectomy to remove the tumors, many people understandably want laparoscopic surgery.
Of course. It's minimally invasive. You only have a few tiny keyhole incisions on your belly, and the recovery time is drastically shorter.
But to get a solid melon-sized fibroid out of a tiny half-inch keyhole incision, you have to break it down.
Yes. To achieve that, surgeons frequently utilize a device called a power morcellator.
Right.
It is essentially a rapidly spinning blade inserted through the keyhole incision. It minces the dense fibroid tissue inside the abdominal cavity, allowing the surgeon to extract it in long, thin strips through the small tube.
So instead of making a large incision to pull the mass out whole, you're blending it up to get it out of a smaller hole.
Exactly.
But if that mass is actually a hidden sarcoma, imagine a hornet's nest inside your living room.
Okay, a hornet's nest.
If you carefully wrap the entire nest in a bag and carry it out the front door, which would be like a traditional open abdominal surgery, you're safe.
Makes sense.
But if you try to chop the nest into tiny pieces to pull it out through the mail slot, you agitate it. You release the swarm everywhere inside the house.
If we connect this to the bigger picture, that analogy perfectly captures the clinical devastation.
That's a scary thought.
It is. If a surgeon uses a power morcellator on a presumed benign fibroid, but it turns out to be an occult, undiagnosed leiomyosarcoma, the morcellation process fragments the tumor.
It releases a swarm.
Yes. It spins highly aggressive, malignant cancer cells throughout the entire abdominal and pelvic cavity, seeding the disease everywhere.
And what does that mean for the patient's prognosis?
The survival data is grim. If a hidden sarcoma is morcellated, the patient's 10-year survival rate plummets from 57.2% down to 32.2%.
Wow. From 57 to 32%.
Yeah. You are effectively taking a contained, potentially curable early-stage cancer and instantly upstaging it to an advanced, widespread disease.
Which completely changes the conversation around surgical options.
It does. It is why informed consent is so absolutely vital and why major medical guidelines have shifted dramatically in recent years.
Right, because for patients in perimenopause or menopause where the statistical risk of sarcoma is highest, the guidelines now strongly advise against the use of uncontained power morcellation.
Exactly. If there is any clinical suspicion at all based on rapid growth or resistance to medication, the standard of care shifts to a full en bloc removal.
En bloc meaning removing it all in one solid piece.
Correct. It means making a larger abdominal incision so the entire uterus or the intact mass can be lifted out without ever breaking the tumor's outer capsule.
So you're keeping the bag sealed.
Exactly, completely neutralizing the risk of spreading hidden cancer cells. The minimally invasive option with the faster recovery time isn't always the safest option if you fall into that higher risk demographic.
So what does this all mean when we step back and look at the whole picture?
It's a lot to take in.
It is. Uterine fibroids are fundamentally estrogen-hungry tumors. For most of a person's reproductive life, they grow slowly and predictably, along with the monthly menstrual cycle.
Right.
But perimenopause breaks the communication between the brain and ovaries, throwing a massive wrench into the system. The loss of regular ovulation means no progesterone to hit the brakes.
None at all.
The result is a chaotic buffet of estrogen that causes a brutal, temporary flare-up of rapid fibroid growth and terrifying heavy bleeding.
But the chaos does eventually end. The transition into postmenopause brings the final, permanent drop in hormones that starves the fibroids, shrinking them, and finally bringing relief.
As long as you aren't feeding them with, uncalibrated HRT.
Right. The challenge is safely and aggressively managing that transitional gap. We have to treat the anemia, protect the patient's mental and physical health from the trauma of flooding, and remain acutely vigilant for the rare red flags of rapid growth that could indicate a sarcoma.
And as we close out this deep dive, I want to leave you with one final mind-bending thought pulled from the research stack.
Oh, I love this part.
We've talked extensively about how to manage these tumors once they exist. But where do they actually come from?
Right?
There's the fascinating area of research exploring the stem cell theory of fibroids.
It's groundbreaking stuff.
This theory suggests that an entire, massive, grapefruit-sized fibroid doesn't start as a cluster of bad cells. It originates from just one single rogue stem cell in the uterine muscle. Just one microscopic cell that suffers a genetic mutation, like the MED12 error we discussed, starts multiplying unchecked and builds an extra thick cellular matrix around itself to lock in the growth hormones.
It's incredible to conceptualize. Millions of abnormal cells, a mass large enough to distort nearby organs, all originating from one microscopic division error.
Right. So imagine the future of medicine. Instead of performing major surgical hysterectomies, instead of enduring years of hormonal chaos, severe anemia, and the anxiety of waiting for the perimenopause fire to burn out.
What if we could stop it early?
Exactly. What if targeted treatments could simply scan for and switch off that single rogue stem cell before the fibroid ever even begins to replicate?
That would change everything.
We wouldn't have to worry about the body throwing gasoline on a fire if we could just stop the very first spark from catching.
A future where we stop the disease at the cellular level before it ever takes hold and impacts a patient's life. That is a future worth researching.
Absolutely something to ponder as we wrap up today's deep dive. If you or someone you love is navigating this transition, know that you don't just have to wait it out. There are answers and there are options. Until next time, keep asking questions and keep digging deeper.